Hello and good day everyone. Welcome to today's video on aortic stenosis. Please like the video and subscribe to support the channel. Since this is the first video, please let us know in the comments if you would like a voiceover or not. Let's begin. Aortic stenosis. It is seen in elderly males. It comprises 1/4 of all patients with chronic valvular heart disease. It is important to remember that the pathology is similar to that of atherosclerosis. Therefore, it is only logical that it is seen in elderly males. Etiology. The most common cause is degenerative calcification of the aortic cusps. Other causes are congenital disease, that is, bicuspid aortic valve, and rheumatic heart disease. Pathophysiology. As mentioned before, the pathophysiology is similar to that of atherosclerosis. The final result is a fibrocalcific response and imposition of calcium hydroxyapatite crystals resulting in a thick calcified stenosed valve. Logically, the risk factors are similar to those of atherosclerosis, namely, low-density lipoprotein, LDL, cholesterol, lipoprotein A, diabetes mellitus, smoking, chronic kidney disease and metabolic syndrome. A few genetic predisposing factors are genetic polymorphisms involving the vitamin D receptor, estrogen receptor in postmenopausal women, interleukin-10 and apolipoprotein E4. A strong familial clustering of cases has been reported from Western France. Here we'll briefly discuss bicuspid aortic valve. Bicuspid aortic valve is the most common congenital heart valve defect, yes. It's more common than a ventricular septal defect. How common, you ask? Well, it occurs in 0.5 to 1.4% of the population. It is more common in males with a 2 to 4:1 male to female ratio. A key point to note is that bicuspid aortic valve presents 10 years earlier than degenerative aortic stenosis. Therefore, if you see an old patient with aortic stenosis, think of degenerative cause. If you see a younger patient, say in his 50s, think of bicuspid aortic valve. How is it inherited? It is inherited as an autosomal dominant trait with incomplete penetrance. However, in patients with Turner syndrome, there is an X-linked pattern of inheritance. The chance of a first-degree relatives of an affected individual having bicuspid aortic valve is 10%. What are the genes involved in bicuspid aortic valve? The Notch1 gene, the endothelial nitric oxide synthase and NKX2.5. An important point to note is that bicuspid aortic valve is associated with certain other defects. One is medial degeneration of the aorta with ascending aortic aneurysm formation. This may lead to dissection. Aortic coarctation can also be seen. What happens to the heart in aortic stenosis? Well, the left ventricle has to pump with a higher pressure to overcome the resistance created by the stenosis. This means that the pressure inside the ventricular chamber will be higher than the systolic pressure generated at the aorta. This pressure difference is called a systolic pressure gradient. How does the left ventricle pump with more pressure? By concentric hypertrophy. This works for a while, but after a limit, this adaptation fails. This leads to a decline in the left ventricle's systolic function, causes diastolic dysfunction and causes irreversible myocardial fibrosis. What is the definition of severe obstruction? Severe obstruction is defined as Number 1, a mean systolic pressure gradient more than 40 mm of mercury with a normal cardiac output. Number 2, an effective aortic orifice area of less than 1 cm² or less than 0.6 cm² per meter square of body surface area. This is approximately 1/3 of the normal valve orifice area.
Symptoms. Symptoms begin when valve area is reduced to less than 1 cm². Once symptoms occur, valve replacement is indicated. Most patients with pure or predominant AS have gradually increasing obstruction over the years but do not become symptomatic until the 6th to 8th decades. In bicuspid aortic valve, symptoms develop 1 to 2 decades sooner. The cardinal symptoms are exertional dyspnea, angina pectoris, and syncope. What is the mechanism of dyspnea? Dyspnea results primarily from elevation of the pulmonary capillary pressure. This is caused by elevations of left ventricular diastolic pressure secondary to impaired relaxation and reduced left ventricular compliance. What is the mechanism of angina pectoris? Angina pectoris usually develops somewhat later and reflects an imbalance between the augmented myocardial oxygen requirement and reduced oxygen availability. Coronary artery disease may or may not be present. However, its coexistence is common among patients aged more than 65 years. The hypertrophied left ventricle causes an increase in myocardial oxygen requirement. Even in the absence of obstructive coronary artery disease, coronary blood flow is impaired to the extent that ischemia can be precipitated under conditions of excess demand. The capillary density is reduced relative to wall thickness, compressive forces are increased, and the elevated left ventricular and diastolic pressure reduces the coronary driving pressure. Remember these terms: coronary driving pressure and reduced capillary density. The subendocardium is especially vulnerable to ischemia by this mechanism. What is the mechanism of syncope? In aortic stenosis, the cardiac output is fixed. This is because the fixed obstruction prevents the cardiac output from being augmented. There is decline in arterial pressure caused by vasodilation in the exercising muscles and inadequate vasoconstriction in non-exercising muscles. Since the cardiac output cannot be augmented to match, there is a fall in blood pressure and syncope. Another cause is a sudden fall in cardiac output due to an arrhythmia. Because the cardiac output at rest is usually well maintained until late in the course, marked fatigability, weakness, peripheral cyanosis, cachexia, and other clinical manifestations of a low cardiac output are usually not prominent until the stage is reached. Orthopnea, paroxysmal nocturnal dyspnea, and pulmonary edema, that is, symptoms of LV failure, also occur only in the advanced stages of the disease. Severe pulmonary hypertension leading to RV failure and systemic venous hypertension, hepatomegaly, AF, and tricuspid regurgitation are usually late findings in patients with isolated severe AS. Physical findings. We will go in the order of physical examination. Let's start with vital signs and general physical examination. Patient may be hypertensive, especially older patients with aortic stenosis. However, late in the disease, when the heart fails and stroke volume declines, the systolic pressure may fall and the pulse pressure narrows. The carotid arterial pulse rises slowly to a delayed peak. This is called pulsus parvus et tardus. A thrill or anachrotic shudder may be palpable over the carotid arteries, more commonly the left. In the elderly, the stiffening of the arterial wall may mask this important physical sign. In many patients, the A wave in the jugular venous pulse is accentuated. This results from the diminished distensibility of the RV cavity caused by the bulging, hypertrophied interventricular septum. Let's move on to examination of the cardiovascular system. The LV impulse is sometimes displaced laterally in the later stages of the disease. This is due to RV enlargement. A double apical impulse due to a palpable S4 when the patient is in the left lateral recumbent position. A systolic thrill may be present at the base of the heart to the right of the sternum when leaning forward or in the suprasternal notch. On auscultation, an early systolic ejection click is frequently audible in children, adolescents, and young adults with congenital valve disease. This disappears when the valve becomes calcified and rigid. Therefore, if you hear a click, think of bicuspid aortic valve rather than degenerative. This is an important clinical point. Split of second heart sound. As aortic stenosis increases in severity, LV systole may become prolonged so that the aortic valve closure sound no longer precedes the pulmonic valve closure sound. This results in the two components becoming synchronous. Later, aortic valve closure may even follow pulmonic valve closure, causing paradoxical splitting of the second heart sound. The sound of aortic valve closure can be heard most frequently in patients with aortic stenosis who have pliable valves. Calcification diminishes the intensity of the sound. Therefore, if the second heart sound is diminished, it implies that the valve is calcified. S4 is audible at the apex and reflects the presence of LV hypertrophy and an elevated LV end diastolic pressure. S3 occurs late in the course of disease, when the LV dilates and its systolic function becomes severely compromised. The murmur of AS is characteristically an ejection systolic murmur that commences shortly after the S1. It increases in intensity to reach a peak toward the middle of ejection, and ends just before aortic valve closure. It is characteristically low-pitched, rough and rasping in character, and loudest at the base of the heart, most commonly in the second right intercostal space. It is transmitted upward along the carotid arteries. Occasionally it is transmitted downward and to the apex, where it may be confused with the systolic murmur of mitral regurgitation. This is called Galavardin effect. In almost all patients with severe obstruction and preserved cardiac output, the murmur is at least grade 3 or 4. An important point to note is that in patients with mild degrees of obstruction or in those with severe stenosis with heart failure and low cardiac output, the transvalvular flow rate are reduced. The murmur may be relatively soft and brief. This is obviously seen in late stage of the disease. Keep this in mind.
Let's go to lab tests. We will go from ECG to X-ray, echo and other tests. On the ECG you will see features of LV hypertrophy, ST segment depression and T-wave inversion. This is called LV strain pattern. Chest X-ray will usually show little overall cardiac enlargement as the hypertrophy is eccentric. There will be rounding of the cardiac apex and a slight backward displacement in the lateral view. A dilated proximal ascending aorta may be seen along the upper right heart border in the frontal view. Aortic valve calcification may be seen in lateral views. In later stages of the disease, as the LV dilates, there is increasing X-ray evidence of LV enlargement, pulmonary congestion, enlargement of the LA, pulmonary artery, and right-sided heart chambers. Echocardiogram will show thickening and calcification of the valves. There will be reduced systolic opening of the valve leaflets and LV hypertrophy. What is a feature of bicuspid aortic valve on echo? Eccentric closure of the aortic valve cusps is characteristic of congenitally bicuspid valves. The next step will be transesophageal echo. This will show the obstructed orifice extremely well, but it is not routinely required. The valve gradient and aortic valve area can be estimated by Doppler measurement of the transaortic velocity. How is this done, you ask? Severe AS is defined by a valve area less than 1 cm². Moderate AS is defined by a valve area of 1 to 1.5 cm². Mild AS by a valve area of 1.5 to 2 cm². How can you tell on echo if there is impaired LV function? There will be LV dilation and reduced systolic shortening reflecting impairment of LV function. However, these are seen quite late. There are some early markers that can help in such a situation. Longitudinal strain and strain rate are two such parameters which show decline in LV systolic function, well before a decline in ejection fraction can be appreciated. Remember, longitudinal strain and strain rate. Echocardiogram can also be used to detect diastolic dysfunction using Doppler indices. Another function of echocardiogram is to identifying coexisting valvular abnormalities, differentiating valvular AS from other forms of LV outflow obstruction, and measuring the aortic root and proximal ascending aortic dimensions, especially in patients with bicuspid aortic valve. Remember, bicuspid aortic valve is associated with aortic root dilatation and such patients are prone for dissection. An important concept to know is low-flow low-gradient aortic stenosis. As mentioned before, when the heart fails, the gradient across aortic valve reduces. This can lead to underestimation of the severity of aortic stenosis on echocardiogram. Dobutamine stress echocardiography is useful for the evaluation of such patients. As the name suggests, dobutamine, which is a positive inotrope, is used to augment the cardiac output, and measurement of gradient is done after this step. It is also important to note that in patients with severe AS, that is, valve area less than 1 cm², who have a relatively low mean gradient, that is, less than 40 mm of mercury, despite a normal EF, are often hypertensive. Their blood pressure must be controlled before making measurements by Doppler echocardiography. Other imaging modality is the CT scan, which will also help in assessing the calcium content accurately. It is also important for obtaining precise measurements of aortic valve orifice while planning for a transcatheter aortic valve replacement or TAVR. What is the role of catheterization studies in aortic stenosis? It is useful when there is a discrepancy between the clinical and non-invasive findings. Also useful in 3 distinct categories of patients. Number 1. Patients with multivalvular disease, in whom the role played by each valvular deformity should be defined to aid in the planning of operative treatment. Number 2. Young, asymptomatic patients with non-calcific congenital AS, to define the severity of obstruction to LV outflow. This is because operation or percutaneous aortic balloon valvuloplasty may be indicated in these patients if severe AS is present even in the absence of symptoms. Number 3. Patients in whom it is suspected that the obstruction to LV outflow may not be at the level of the aortic valve but rather at the sub- or supravalvular level. Coronary angiography is indicated to screen for coronary artery disease in elderly patients with severe AS who are being considered for surgical or transcatheter valve replacement. A cutoff of 50 years is usually taken. This is so that if there is a significant coronary artery disease, a bypass graft surgery can be done in the same setting. The incidence of significant coronary artery disease for which bypass grafting is indicated at the time of surgical aortic valve replacement exceeds 50% among adult patients. This concludes part 1 of our video on aortic stenosis. Part 2 will deal with management. Leave your requests for future videos in the comments below. Thank you and have a good day.